Well, Sophie, thank you so much for agreeing to chat with me today. Super, super appreciate it. I'd love to begin by just hearing about what the Harm Reduction Action Center is and what you all do.
Yeah. Thanks for having me. Really excited. I think the partnership between Dry Bones and the Harm Reduction Action Center is not only an essential one, but also a pleasure. So we're always happy to say hello to your volunteers and help spread the word about the good work that both of us do. So absolutely. The Harm Reduction Action Center, or as I might refer to it, or the HRAC, is the largest syringe exchange in the state of Colorado. We have over 10,000 individuals enrolled with us. There are four programs in the state and over 14 programs statewide. We just happen to be the largest and most active. This is dependent on a couple of different things, but a lot of that has to do with the fact that we're a community-based program. So when you walk into most syringe exchange programs or needle exchange programs, they're going to use a clinical model. So you're going to feel like you're in a nurse's office or a doctor's office. It's going to be a clean environment. You're going to be working one-on-one with the healthcare provider. And that model is really great for some, but doesn't work for everyone. So our community-based model functions a lot more like a shelter. And for that reason, 77% of our over 10,000 folks are experiencing homelessness or transitionally housed to some degree. So that has a lot to do with our numbers in terms of serving the unhoused population in Denver, in addition to housed individuals who are also injecting drugs. So the primary service that we provide is direct service. That's things like access to sterile equipment, syringes, alcohol prep pads, BZKs, tourniquets, and cottons, things that reduce the harms associated directly with injecting drugs on a daily or maybe frequent basis. In addition to that, we provide referrals and direct prescriptions of naloxone on site, the opioid antagonist that will reverse an opiate overdose, literally bringing somebody back to life. People who use drugs and people who inject drugs are first responders in our overdose epidemic. So putting a life-saving miracle drug like naloxone in their hands enables them to have the ability to save the lives of themselves, the people around them, and really empower the community themselves to be proactive about their health, which is a huge part of what we do. We also pass out fentanyl testing strips to combat the overdose crisis in partnership with drugs being cut with fentanyl, a really high, just a really, really potent opioid. So giving our folks the ability to test a drug for the presence of fentanyl is just another example of direct service in terms of empowering people who inject drugs in our community. So outside of direct service, we also focus quite a bit on policy. We've passed 8 pieces of statewide legislation, 2 in the city and county of Denver. And when we pass legislation, we try and do it on a statewide basis so that people outside of Denver can benefit from that policy, right? So in 2012, my bosses, Lisa and Ruth, passed legalized syringe access for the whole state. So because of our efforts as an organization and Lisa and Ruth's efforts as individuals, we were able to pass syringe exchange for everyone so that places like Pueblo, Grand Junction, Fort Collins can also start and begin to provide those services in their communities as well.
Can you speak a little bit about what you think people's misconceptions are about drug use or people who use drugs or IV drugs?
Yeah,
anything to say to those things?
I think one of the biggest misconceptions that we see, not only in service providers and healthcare providers, but really just in our community in general, is the idea that people who use drugs and people who inject don't care about their health, that they don't care about their friend's health, or they don't care about taking care of themselves and making sure that they live a happy, prosperous life. And through the work that we do at the Harm Reduction Action Center, it is so clear that when given a space where people feel seen, recognized, and safe, that they do feel comfortable acting on acting on that desire to take care of themselves. So I think that in spaces specifically, healthcare spaces like clinics, emergency rooms, PCP, primary care physicians, there is so much stigma associated with people who inject drugs. And there's so many assumptions that we can make about those individuals. And that's because in those spaces, our participants are not able to share freely about their experience without being told that they need to be sober or they need to be abstinent in order to be happy and be successful and be healthy. We know that's not true. So the cool thing about the HRAC is that everyone who signs up with us is doing so willingly. You are never mandated to be there. There is no court order for you to be there. There is no family member that can force you to sign up with us. It is always one person who injects, waking up one morning and saying, I really need access to sterile equipment because I want to take care of my body and my health. So every single one of those 10,000 individuals is actively caring about and protecting the health of themselves, as well as everybody that they help provide services for. So I would say one of the biggest misconceptions is that they don't care. The truth of that statement is that they are not given stigma-free environments to share their problems and their experiences in a way that addresses their health issues outside of their use. It's often so focused on someone's use experience that I might present to the ER with a soft tissue infection, and all I'll get told is, slap a Band-Aid on that, and here's 6 programs for you to get into treatment today. But that's not why I showed up, right? And if I'm going into an ER with a soft tissue infection, that's because I'm injecting maybe improperly because I was never taught to do so correctly, that ER doc should be saying, hey, do you go to your local needle exchange? Do you know about these services? Because harm reduction is so essential for these individuals, and it's not medical providers that are referring them to our program. It's the majority of the referrals that we get are from friends. It's word of mouth. It's one person who uses drugs or injects who's telling another person, hey, I know you're having a hard time. You should go into this facility and they can really get you taken care of. We actually get more referrals from law enforcement than we do healthcare providers.
Wow. Yeah. Can you speak some about y'all's relationship with law enforcement? I think it's fascinating.
Yeah, absolutely. I think we boast an incredibly strong and necessary relationship, not only with DPD, but law enforcement across the state. And the reason that is because they're necessary stakeholders in the safety of our participants, right? There's nothing that we can do to eliminate the interactions between a person who injects drugs and the criminal justice system or a law enforcement officer. So what we can do is reduce the harms associated with that. And by doing so, we created better relationships with DPD. We're in District 6 in Denver. My boss, Lisa, meets with Commander Sanchez almost on a weekly basis to make sure we're on the same page about what we're doing and how we can be better community members in our partnership. We have passed paraphernalia exemption cards, which give our participants of our program the ability to carry their syringes freely without fear of being ticketed. That said, in order to be exempt, they are required to disclose the location of their syringes to law enforcement. So the idea there is that our law enforcement officers aren't getting pricked and our folks aren't getting ticketed for being proactive about their health. Because harm reduction at its absolute true base should benefit not only people who inject drugs, but every single person in the community that engages, maybe you use a park, or you're a law enforcement officer, or you're a doctor, or you're a person who lives outside. Harm reduction should benefit all of those people. And I think that my boss, Lisa, and Ruth have done an incredible job of creating a realistic relationship between law enforcement and our participants, as well as staff of our program. One of my favorite examples to give, at our old location across the street from the Capitol, state troopers, if they were trying to, walk past us to cross the street, or to get maybe go down the street, we used to watch them cross the street and walk on the other side of the block and then cross again, so that they didn't walk in front of our participants and make that space unsafe for them. Like that's amazing. That's something we didn't ask them to do. They knew that their presence was inherently making our participants unsafe, and they want our folks to have those services. So they would go out of their way to make sure that they were providing a safe space for folks. So just a quick example, but paraphernalia exemption and just having those conversations with law enforcement is so important, because harm reduction should benefit, your everyday law enforcement officer just as much as it should an individual who lives outside and injects heroin daily.
Yeah. Can you speak some to, I love this idea that it's to benefit everyone involved, like everyone who might use a park, who might use a public restroom. Well, if those existed, but like a restaurant restroom, things like that. Can you speak some to what you would say to someone who thinks that the things that harm reduction does is enabling people?
Sure. I do enable people. I enable people to be a healthier, safer them today, right? We give individuals the ability, like I was saying, to actively take care of themselves and the people around them. So I give individuals the ability to save the lives of their friends. I give people the ability to get access to mental health care and substance use treatment. Maybe that's medicine-assisted treatment. Maybe that's some sort of housing, whatever that might be. Do I enable drug use? Absolutely not. We don't live in a magical world where if we did A, B, and C, drug use would disappear, right? We live here. This is reality. People use drugs. Harm reduction, again, at its core, assumes that people, no matter what, are going to use drugs, and that's the absolute truth of our society. So knowing that, how can we take that truth and reduce the harms associated with that, right? So at the end of the day, we're doing things like greatly reducing the transmissions of HIV and hepatitis C in our community, reducing rates of public overdose and overdose in general. We're going to increase access to mental health programs. We're going to increase access to substance use treatment programs. We are going to ameliorate relationships between patients and their medical care professionals. All of these things happen in harm reduction spaces and improve the lives of people who engage with our program. If our program didn't exist, you wouldn't see decreased rates of people who inject drugs on the street, right? Or maybe in their homes. You would see increased rates of improperly discarded syringes. You would see more public overdose. You would see way more interactions with law enforcement and our participants in terms of needle prick injuries and responding to overdoses and just altercations in general. At the end of the day, you know, the enabling argument fails to recognize all of the work that we do and all of the community stakeholders that we work with. It's also not true. It's statistically proven that the existence of harm reduction programs does not increase or decrease the amount of drug use in a community. It remains stagnant. However, it has a massive effect on those things I've already mentioned: disease transmission, overdose rates, things like that.
That's so great. I love the kind of reclaiming of the word enabling. Like, yeah, we are enabling, but we're enabling all these really good, positive, healthy, like harm reduced things.
Right.
That's so good.
Exactly.
Can you speak some to the supervised injection sites and what those are?
Yeah.
And why you all think that those are good things?
Absolutely. So Haley, you already made a really great point, right? There's no such thing as a public restroom, especially in the days of COVID-19. So if I live outside and inject heroin daily, I have a couple of different options. The first one would be injecting outside. If I am injecting with other people, with a group of folks, I'm going to draw attention from onlookers, bypassers, and law enforcement. So often, if I'm living outside and injecting, I'm going to try and do it by myself. I'm going to do it rushed. That's somewhere that's out of space, you know, out of sight, out of mind. So most commonly, that's an alleyway. So I'm going to use rushed, unsterile injection practices, and I'm going to be by myself. At the end of the day, we know that the easiest way to prevent an overdose is to not be alone. But if I want to decrease my rate of arrest or chance of arrest, then I want to do these things by myself. My other alternative is going into a business bathroom, public restroom. So although those options were somewhat available to people before the pandemic, they're even less so available now. But businesses for a long time have been locking their bathrooms and not allowing folks to get access to those in response to people injecting in those bathrooms. The reason I would inject in a bathroom is because it gives me a safe, sterile environment where I can slow down, make sure I'm doing things correctly, like prepping my skin, using a tourniquet, and doing all these things to take care of myself better. But then I'm putting the burden on that of the community, on the business owner. If I overdose in those bathrooms, does the 20-year-old barista who works at Starbucks know how to respond to my overdose? Absolutely not. That's not what she signed up to do, right? So we know, again, that this is the reality. You're not going to eliminate public injecting, but what you can do is bring it into a controlled environment where I'm not using taxpayer dollars to call 911 on somebody injecting in my alleyway behind my home, when by the time law enforcement gets there, they're gone, right? I'm not using business resources to have traumatized employees of finding improperly discarded syringes or people overdosing in their bathrooms. And I'm bringing this into a controlled environment, into a safe and sterile space where people can bring pre-obtained drugs into a space where they have access to all the sterile equipment that they need and inject their drug of choice, where someone like myself, who signed up to do this work, who's trained, and who knows exactly what to do in this situation, can respond to me in the event of an opiate overdose, stimulant overdose, whatever it might be. So through the implementation of supervised injection facilities, you take those effects of a syringe exchange program and you push them tenfold. You thought you were already preventing overdose with a naloxone distribution program. That goes through the roof when you all but completely eliminate public injecting in a city itself, right? So these spaces exist across the globe. They've existed for 30 years. There are over 160 facilities in the world, and there has never been a recorded opiate overdose death in any facility.
Wow.
Closest,
out of 160?
correct, or more. The closest ones to the United States exist in Canada. Historically, they've been in places that have more socialized healthcare systems, Switzerland, France, Denmark, places like that, for example. So we have existing data. We know these programs work. What we don't have is, kind of a precedent set within the United States. What we expect is that once we get one program established and it's proven to work, the rest of the programs will fall like dominoes. So luckily, they're really pushing forward with a program in Philadelphia, and we're hoping that once they get up and running, they're able to turn that data around. We'll be able to rely on that specifically in the United States and start really adequately serving people who inject drugs in this country.
Sure. Why do you think some people are so opposed to those supervised injection facilities? Because I know I've had some conversations with some people, and it's just really interesting to see people who haven't had firsthand experience or don't even know anyone who has firsthand experience get so emotionally charged when talking about these things. Why do you think people get so kind of revved up about it?
I mean, the war on drugs has conditioned us to think so many things about drug use. One is that those individuals are dangerous, that they deserve to be incarcerated, that behavior is a choice, and that they're making that choice, and that if we were bringing that into a space, again, bringing up that idea of enabling, that would be enabling individuals to use those substances. These emotions, from our perspective, often come from a totally justifiable place of fear, right? It's not understanding that environment. It's not understanding how that policy affects these communities and how they ultimately affect you, even if you don't think that they do, right? So it's the unfortunate messages of the war on drugs that have really embedded themselves into our communities that lead people to want or to need to come from a place of fear to hold on to what they know, right? It is easier to think that, hey, well, why don't you just go get treatment? I don't understand why you don't just quit and go get treatment. But if you work in this world, if you understand, or maybe if you just know somebody who has struggled with addiction and is somebody who uses substances, you know that it's not that easy, that you can't just walk up to a clinic and say, hey, I'm ready to quit today. Right? Because there are so many barriers, especially for our more marginalized folks. If you live outside, if you're a person of color, if you don't have access to an ID, there's so many factors that can change how or why someone might not be able to get access to treatment. It goes without saying that you should have increased access to treatment, not only outside of needle exchange and supervised injection facilities, but also within those spaces. But that being said, that doesn't mean that they shouldn't exist, right? So I think that those arguments do come from a place of fear and from a place of ignorance and not understanding the perspectives and the realities of someone who's engaging with those systems. That said, I also think that people often don't think critically enough about it, right? They don't think about all of the intersections of what somebody publicly injecting, how it affects them and how it affects their taxpayer dollars. And I often find that although it's dehumanizing, because for harm reductionists and people who work in this community, if I'm telling you that it saves lives, then what else do I have to tell you, right? But a lot of times you have to bring in other factors, right? You have to talk about the effect on law enforcement. You have to discuss the effect on taxpayer dollars. You need to talk about what legislation looks like for the war on drugs, right? And so it's important to present that full picture, because I think often for people like myself, if you tell me it saves the lives of somebody I care about, then I don't have any follow-up questions. But it's so important to present the full argument, and then you're going to ultimately begin educating folks. And maybe you don't win that today, right? But maybe 4 weeks from now, after they've pushed themselves to think more critically about it, do their homework, look at the research and see what exists, they might come back and say, hey, this was really scary to me at first, but I've taken some time to process, and it's actually completely logical and probably the right move. What can I do to be helpful? And we see that all the time.
Yeah. Yeah. And I imagine it's a lot easier to kind of ignore the humanity of it if you're disconnected from that community, if you're disconnected from those people. If you're shoving people off to the side and just kind of saying, all right, get out of sight, get out of mind, then it's easier to see them as a statistic as opposed to, oh, you're a human life that deserves
exactly
some huge degree of dignity.
Yeah.
Yeah. Can you speak a little bit more to rehab and treatment? And because I know I've heard you talk before about just how inaccessible that is in our community.
Yeah,
Can you speak a little bit more to
sure.
that?
So there's a couple different types of treatment, right? And it really comes down to, let's talk about what most people think when they think of treatment. You think of rehab, right? Fly to Florida, go to an inpatient facility for 4 weeks. I eat pancakes with my friends in the mornings, and I have group therapy in the afternoon, right? Something like that, something we've all seen on TV. Well,
Pancakes and
right? Those are going to be highly inaccessible to folks who don't have private health care, who can't pay on demand, and who are only using certain substances. So for the specifically for the community I serve, we almost never get folks into programs like that because they have either no coverage or Medicaid coverage. They're not able to pay out of pocket, and they might use a drug that's more stigmatized in those places. A lot of those facilities will work with people who are using benzodiazepines. They'll work with individuals who are using opiates. But if you start talking about stimulants, a more stigmatized drug like crack or meth, they're seen as dangerous, right? So that's like the number one ideal, is like this beautiful inpatient program that we already know we don't have access to. Then you could talk about maybe a state subsidized inpatient program where you go through detox and you live in a halfway house or something like that. Again, you still have to get on a waiting list. You have to have an ID. You have to have the right substances in your system. You have to be willing to use medicine-assisted treatment. There are so many requirements for folks to be able to get into these facilities. And if you are a person who injects and lives outside and doesn't have documents and has already had terrible experience with healthcare professionals, then gaining that access to those systems is so difficult. At its simplest form, treatment can look like medicine-assisted treatment, and that's some sort of replacement therapy, right? That's most commonly known as a Suboxone or methadone or buprenorphine. And that is a medication that takes the place of my substance use. It might curb my withdrawals. It might just stabilize my use or whatever that might be. Again, for those programs, I have to have an ID. I have to, pay out of pocket or have some sort of medical coverage. There's no way, there are not enough adequate ways for somebody who's ready that day to get treatment to walk into a facility and have somebody say, well, at the end of the day, we'll make sure that you're taken care of. Because that's not how it works. Most of the time, people are turned away. Most of the time, they don't have the right things that they need to begin those programs and get their foot in the door. And what's really difficult about that is because I may be ready today, but tomorrow and for the next 2 weeks, I'm not ready. You lost me. Maybe that window of me being clear and ready doesn't last very long. And that's not because it has to, right? Because then I leave your facility and I go back and I sleep on the street and it's a hard night and it rains and someone steals my stuff. And of course I want to get high because it makes me feel better. And it's something consistent that I know that I can rely on. And I think that there's a lack of understanding of really supporting people in their moment when they're asking you for help. You should go out of your way to make that happen. We're not able to do so because of the lack of access to these programs. And that's all assuming you use a drug that's not stigmatized. If I'm an everyday meth user, I don't care if I smoke it, inject it, snort it, whatever it might be, there are no medicine-assisted treatment programs for me. Most inpatient programs won't work with me because they see me as dangerous because of the behaviors that are associated with a stimulant. We know these to be stigmatizing and largely untrue. It's more about the individual, how much you're sleeping, do you have access to mental health care treatment? All of these things play into someone's behavior, right? It does not come down to the drug itself. Unfortunately, if I'm an everyday meth user, I just don't have options. So it can be everything from how much money do you have and how much medical coverage do you have to do you live outside and what type of drug do you use? There are so many barriers that keep folks from getting access to these programs. And that in itself makes supervised injection facilities and needle exchanges absolutely essential because these are small time interventions that are effective in the sense that they save taxpayer dollars and are inexpensive to implement. A syringe is a cent, it's 1 penny, right? And if I'm able to have access to sterile syringes, it might prevent me from HIV that will cost taxpayers tens of thousands of dollars annually to treat me through some sort of subsidized program. So if we can focus on expanding access to treatment, which takes time, money, infrastructure, policy. It's a massive change, right? We have to change the systems of the healthcare. We have to change how people are granted access to those things. There's so much to do. And we advocate for that all the time. But what we can do today is bring folks into a supervised environment and reduce the harms associated with that until we can get them into treatment. Harm reduction is not an end-all, be-all cure for the overdose epidemic or substance use in this country in general. What it is a realistic option and solution for folks that want to be healthier, safe for them today, especially when paired along with larger scale treatment and expansion to that treatment.
Yeah, I love the acknowledgement that it's like harm reduction in and of itself obviously isn't attacking the bigger structures that are at play, although you obviously do that through like policy and those kinds of things that y'all are involved in, but that it is a necessary, like in the meantime, thing to do for people and service to provide for people. What are your thoughts on housing programs that require sobriety as a like prerequisite for entering into that housing?
I think that housing programs themselves are essential, and our folks are grateful for any opportunity to be included in a housing program. That said, I think the sobriety requirement does a disservice to the individuals that you're trying to work with, because it fails to recognize the reasons why you may be homeless in the first place and why you've been using drugs in the first place. Housing first is healthcare. If you're able to house an individual first and foremost, then once that individual is inside, then they're in a much better controlled environment to be able to reassess their use. What does it look like for them to begin to taper on their own? What does it look like for this person to begin to smoke instead of injecting, right? Because that's harm reduction. What does it look like for this person to begin to dose daily at a methadone clinic, to start using medicine-assisted treatment? Well, all of that's easier when I'm inside. I have a roof over my head. I don't have to lose my things daily. I'm not having fear of arrest or assault, and I'm in a safe space where I'm able to sleep on a more regular schedule, right? I'm also then able to address my mental health needs. I'm able to address my food security needs. I'm able to address needs for the rest of my family or maybe the children I might have. Once you bring somebody into a home and give them their own space, it is so much easier for them to address all of the other things that go on in their life. But what's really, really difficult for somebody is for the program to expect them to fix what they see as their, worst habit or their use before gaining access to housing. So once I get into that housing, my whole environment has changed. I'm not with my friends all the time. I'm not with my community that I used to live with on the street. And not only that, but I don't have that sense of familiarity in my routine, right? So often I think it's doing a disservice in the sense that it fails to recognize all of the other problems or needs that somebody might have, while perpetuating that stigma associated with the idea that, well, because you use drugs, you shouldn't live inside. And you cannot live inside until you don't use drugs anymore. Why would that make me want to be better? Why would that make me want to join the society that you're trying to get me to be a part of? You're saying that I'm not doing enough for you, so you want me to do something to get into and play this game and live up to your standards. No. Harm reduction is literally meeting people where they're at. It's coming in contact with an individual and saying, what can I do for you today? And if that person says that I want to live inside, you shouldn't expect that person to stop their use before getting granted access to housing. In our opinion, that's a really unrealistic, that's an unrealistic expectation that fails to meet the needs of that individual or that community member, all while perpetuating that stigma.
I've heard about the idea of housing first being in and of itself like harm reduction in and of itself healthcare, which I super appreciate.
So, yeah.
How do you see systemic racism? You've mentioned it. You mentioned race a little bit earlier. How do you see that as intersecting with the work that you all do in the community that you all are in?
Sure. Well, when talking about harm reduction and the war on drugs, one always has to make an acknowledgement to the harms that the government, politicians, community leaders, and largely white citizens of the United States did to communities of color, both during the crack epidemic and long before that. Harm reduction was not seen as a tool until the AIDS epidemic presented itself as a reaction to wanting to curb HIV, right? But when you look on the history of the war on drugs in the United States, over and over and over again, you see over-policing and high incarceration rates in communities of color. You see over and over again how disproportionately our war on drugs in the United States has affected low-income communities, often those Black communities, Latino communities, and Indigenous communities. To be a harm reductionist and to be advocating for changes like supervised jail facilities and increased access to treatment, it is simultaneously essential that we acknowledge the harms that we have created amongst communities of color, and we go out of our way to create space for people who inject drugs and people who use drugs who are individuals of color in the United States, not only to be lifted up in our movement, but to be leaders in this movement. Because harm reduction itself was led by Black men and women. It was led by trans individuals. It was led by non-binary individuals. It was led by people who have been for years targeted by the war on drugs. And even throughout all of that, high rates of incarceration, high rates of police violence, high rates of over-policing in those communities, they still come out saying harm reduction, understanding how harm reduction can benefit their communities. So first and foremost, it's understanding the history of the war on drugs and why and how harm reduction should be implemented, but also why it wasn't implemented sooner, right? And that is blatant racism. And because it supported that the criminal justice system as we know it, right? Moving forward, as I was saying, including leadership and including the voices of LGBTQ and Black, Indigenous people of color in these harm reduction spaces is essential because they are so heavily affected by the existing laws that we have as a result of the war on drugs, that without their input and without their leadership, this wouldn't be a true harm reduction movement, and the change that we are implementing wouldn't ultimately affect the people that need it the most. I don't know if that accurately answered your question, but I guess it's really a lot about being informed by our history and how we need to include those voices in this movement to make sure that mistake is not made again.
Sure. Yeah, absolutely. Thank you for your words. That was very, very helpful to keep in mind and to know.
Yeah.
For people who are interested in being involved with Harm Reduction Action Center, what is the best way to get plugged into that community?
So the best way to get plugged in with us here in Denver is to come over for a tour. If you're not comfortable with an in-person tour due to COVID restrictions, although we all wear masks, socially distance, all those types of things, we're happy to get with you over email and get you engaged with us in maybe a different type of volunteering, but we're totally relying on volunteers. I'm always happy to have more. Shoot us an email, look us up on Google. We have a lot of informational videos and background. It's always good to learn a little bit more about the organization before you get involved. But check out our website. We have our volunteer form on there, and we'll kind of get going with you over email. But we would love to have you.
Well, thank you again so much for taking the time to do this. Super, super appreciate it. And I'm really grateful for the work that you all do at the HRAC. And yeah, just for meeting people where they're at and continuing to declare the humanity and dignity of every single person in our community.
Thanks, Haley. Happy to do it. We love Dry Bones. You guys are the best.
Yeah. Well, thanks so much.
Yeah, no problem.